Hello, and thank you for joining us for our second cardiovascular genetics webinar. We are excited to share with you our new test offerings for inherited arrhythmias, cardiomyopathies, and other hereditary cardiovascular conditions. I will begin by introducing our speaker, Melissa Dempsey. Melissa is a genetic counselor currently in the role of product manager for our cardiovascular genetic testing at Ambry Genetics. Prior to joining Ambry, Melissa developed new cardiovascular and oncology genetics programs at Parkview Health in Indiana. In addition, Melissa served as a genetic counselor and director of clinical services and education at the University of Chicago for 8 years. Melissa is an active member of the National Society of Genetic Counselors and the American College of Medical Genetics. She is also faculty for the Indiana University School of Medicine. In Melissa's current role, she is responsible for cardiovascular product development, the creation of marketing materials, and educating team members and clients about our cardiovascular offerings. Please join me in welcoming Melissa Dempsey as she shares with us what's next in cardiovascular genetics. Melissa?
Thank you, Laura, and thank you, everybody, for joining. I know we have a lot of things to cover with our new panel, so I'm going to get started right away. So most of you, if you do cardiogenetic counseling, you realize some of the impacts that genetic testing can have on cardiovascular diseases. But just a brief overview here, cardiovascular genetic testing can help us identify the etiology of a disease, may help us confirm a diagnosis, and may impact management. More importantly, this genetic testing can allow us to do cascade testing on family members, which can allow us to figure out which family members are at high risk for this disease and which are not at risk. This helps us do earlier screening and can save lives. Most of these conditions are inherited in an autosomal dominant inheritance pattern, although they may exhibit variable expressivity or decreased penetrance and may not appear like a classic autosomal dominant disease. This is how they are typically inherited. Ambry has several different types of cardiovascular genetic testing in our menu. We have panels for inherited arrhythmias, inherited cardiomyopathies, along with aortic aneurysms and dissections. We also offer testing for familial hypercholesterolemia. All of our new panels that we'll be just talking about today include full sequence analysis by next-generation sequencing, along with deletion duplication analysis by a custom microarray for all of the genes. There are a few exceptions, less than 5 genes overall, that we do not have deletion duplication analysis available for, and those are specified more on our website and in our materials. But a vast majority of the genes include all of the deletion duplication analysis. So let's start by talking about the inherited arrhythmia testing. For arrhythmias, the two main tests that we offer are the RhythmFirst and RhythmNext panels. These are great choices for testing for long QT syndrome. In long QT syndrome, as you may be aware, genetic testing is the only definitive test to really rule in or rule out this syndrome for family members. Long QT syndrome is associated with this prolonged QT interval that can be seen on an EKG. However, this finding can be transitory. It can come and go in individuals. So when you do an EKG on family members and you don't see this long QT pattern, it does not mean that the patient is not affected, and so it cannot rule out the condition. Thus, genetic testing can be very helpful in these situations. Ambry offers the RhythmFirst and RhythmNext panels. RhythmFirst includes 3 genes, KCNH2, KCNQ1, and SCN5A, and RhythmNext includes 34 genes. All of these genes are associated with long QT syndrome, Brugada syndrome, and other inherited arrhythmias. RhythmFirst includes the 3 most common genes for long QT syndrome. 75% of all patients with long QT syndrome have a mutation in one of these 3 genes. It also includes SCN5A, which is the most common gene for Brugada syndrome, and 15 to 30% of patients with Brugada syndrome have a mutation in this gene. In addition, 2 of the 5 genes for short QT syndrome are KCNH2 and KCNQ1, which are also included in the RhythmFirst panel, thus making this small panel of just 3 genes a great first-tier option for these three conditions. There are also some therapeutic implications for long QT genetic testing. One example here is in choosing the best medication for a patient with long QT syndrome. Most physicians or cardiologists would prescribe a beta blocker for anyone with long QT syndrome. However, with whatever gene out of those three most common genes, whichever gene is causing the mutation in the patient can impact what treatment would be best. For a patient with long QT type 1 or a mutation in KCNQ1, these beta blockers are extremely protective. However, with a patient who has long QT2 or a mutation in KCNH2, this beta blocker is only going to be moderately protective. And most concerning, those patients who have a mutation in SCN5A or have long QT type 3, cardiologists may want to consider using propranolol as the preferred beta blocker, and they may want to add one of these other medications for the patient to give them extra protection. The HRS, Heart Rhythm Society, and the European Heart Rhythm Association together published some guidelines in 2011 to help us know which patients should have genetic testing and where it's most appropriate. And their class 1 recommendation is the strongest recommendation that they give in their guidelines. And this is what they give for long QT syndrome. They say that genetic testing for long QT syndrome is a class 1 recommendation for those that have a suspicion of long QT syndrome or those who come up with a prolonged QT interval within these limits. So I've talked a little about these three genes that are included in RhythmFirst. KCNQ1, KCNH2, and SCN5A are the most common genes for long QT syndrome. And you can see they make up about 75% of all patients. About 25% of those with long QT syndrome have an unknown cause, and none of our genetic testing that's available right now will identify the cause in these patients. There are about 6 other genes that have been reported to cause long QT syndrome, but together they make up less than 5% of all patients, and that falls in this other piece of the pie here. These genes are all included in the RhythmNext panel, which may be an excellent second-tier option. So in summary, RhythmFirst is a great first-tier option made of the 3 most common genes for long QT syndrome, and this accounts for over 90% of the known genetic causes of long QT syndrome. However, some patients with long QT syndrome may have a mutation identified in our RhythmNext panel, which includes 34 genes associated with long QT syndrome, along with some other inherited arrhythmias that are all listed here. Here's another way of looking at the RhythmFirst and RhythmNext panels. We've talked about long QT syndrome here, and you can see that about 75% of patients will be identified, their mutation will be identified on RhythmFirst. The small sliver here, less than 5%, will be identified on RhythmNext, and about 25% overall remain unknown. For Brugada syndrome, there is a much higher proportion of patients that remain unknown after all genetic testing that is currently available is performed, but about 25 to 30% of patients will have a mutation on RhythmFirst because of that SCN5A gene. And again, about 5% will be discovered to have a mutation in one of the genes on RhythmNext. I wanted to point out specifically that deletion duplication analysis is very important in long QT syndrome, as well as some of the other cardio conditions that we'll talk about. But specifically for long QT syndrome, deletions and duplications involving KCNQ1 or KCNH2 have been reported to account for about 3% of all mutations in these 3 genes. The specific publication from 2011 showed that the percentage of deletions in these 2 genes is actually higher than the percentage of mutations found in all of the other genes that cause long QT syndrome. Thus, it might be a better idea or more effective testing to do RhythmFirst in a patient than it would be to do a larger arrhythmia panel that doesn't include deletion and duplication analysis. So the RhythmNext Reflex is an option we have that is very efficient and cost-effective. You can order RhythmFirst, the panel of 3 genes, and get a result in about 3 to 4 weeks. If a clear mutation is found, this report is sent out to you. If it's negative, we will automatically reflex to RhythmNext. In a total of 6 to 8 weeks, you'll get your results, and the patient is only billed for either RhythmFirst or RhythmNext, not both panels. Now onto CPVT next. This is a panel that we offer for catecholaminergic polymorphic ventricular tachycardia. And this panel includes 6 genes with a turnaround time of about 4 to 6 weeks. CPVT next, as we said, is made up of 6 genes that cause CPVT. And you can see that RYR2 is the most common gene associated with this condition. It makes up over 50% of all patients. In addition, the CASK2 gene is also found in about 5% of patients. And the other 4 genes found in this panel fall into a smaller piece of the pie here. And we have about 40% of patients with CPVT that will still be unexplained. Like long QT syndrome, the HRS and EHRA recommend genetic testing for all patients with a suspicion of CPVT. This is also a class 1 recommendation. And it is also really important to include deletion duplication analysis for this condition. There's been several case reports that cite deletions in the RYR2 gene specifically within exon 3 that have been reported, and so we include deletion duplication analysis on all of our panels, and this is very important not to overlook. ARVD next is another panel we offer for arrhythmogenic right ventricular dysplasia. This is a panel of 8 genes and also has a turnaround time of 4 to 6 weeks. Again, looking at the mutation distributions for ARVD, there are about 8 genes that cause ARVD, and mutations have been identified in about 50 to 60% of patients. You can see these are the most common genes, with PKP2 making up about 25% of patients overall. And then these other 3 genes have significant percentages, with the other 4 together making up about 5%, or a very small piece of the pie. We can see about 40% of all ARVD overall still remains unexplained. And again, deletions and duplications are significant, and up to 3% of patients with ARVD have been found to have a deletion or duplication within the PKP2 gene specifically. So here's some publications that show that. So we want to be sure not to forget these important abnormalities. So in an overview of Ambry's genetic testing options for inherited arrhythmia, this shows you the RhythmFirst panel. CPVT next and ARVD next are nice targeted panels for those conditions. And then RhythmNext is the larger arrhythmia panel with 34 genes. It includes all of the genes for long QT, Brugada syndrome, CPVT, and ARVD together in RhythmNext. CardioNext is a panel we'll talk about a little later that includes all of our arrhythmia and cardiomyopathy genes. So moving on to our cardiomyopathy testing available now at Ambry. We have similar reflex options available for cardiomyopathy, specifically for hypertrophic cardiomyopathy, and similarly they're called HCMFirst and HCMNext. HCMFirst is a panel of the 2 most common genes for HCM, MYBPC3 and MYH7, and HCMNext is 25 genes known to cause hypertrophic cardiomyopathy. HCMFirst has a similar turnaround time of 3 to 4 weeks, while HCMNext takes about 6 to 8 weeks. Hypertrophic cardiomyopathy is one of the most common inherited cardiovascular diseases that we'll talk about today. It occurs in about 1 in 500 individuals, and although it is inherited in autosomal dominant fashion, about 30% of patients will have a de novo mutation. So finding a negative family history does not reassure you that this is not genetic and that it's not running in the family. It's still very likely that it could be de novo and will be passed down to the patient's family members. Penetrance is almost complete, but there is a variable age of onset and severity. So you'll see patients who start showing symptoms in even their teens or 20s and fairly severe. But then in the same family, you can see patients who don't start showing symptoms until their 60s or 70s or later in life. So this can make it look like it's incomplete penetrance or even look like a de novo mutation. Similarly, HRS and EHRA recommend genetic testing for HCM as a class 1 recommendation. And this is based mostly on the high likelihood of finding a disease. They require more than a 40% chance of finding a mutation in order to get a class 1 recommendation. and they do take into account that there is a risk for finding variants of unknown significance, but they consider that risk low enough that it is still worth doing the genetic testing. And the genetic testing for HCM is mostly a benefit for family members to do cascade testing and screening. So looking at the mutation distribution for HCM, there are two genes that are implicated most in patients, NYH7 and NYBPC3. Overall, about 50 to 60% of patients have a mutation discovered to cause their HCM, and about 50% overall is in either NYH7 or NYBPC3. You can see there's another couple fairly common genes that have about 5% each, and this other piece of the pie is the other 21 genes that are part of our HCMNext panel that make up together less than 5% of all patients. So about 40% of patients with HCM are still with an unknown cause at this time, but a vast majority of those we can explain fall in one of these two genes. So in summary, HCMFirst is a panel of the two most common genes for HCM, and mutations in these genes make up 80% of the known genetic causes for HCM. This makes it a very good first-tier option. However, about 20% of patients that may have a mutation explained at this time will have a mutation in one of the other genes found in HCMNext, and that is a total of 25 genes. HCMNext does also include these two genes found in HCMFirst, so you can go directly to that panel if you like. So we also have an HCM reflex option similar to the rhythm reflex option, and this is, again, a very efficient and cost-effective way of doing testing. HCMFirst includes the two most common genes, and you get results back in 3 to 4 weeks if there's a clear mutation that's found. If it's negative, we'll automatically reflex to HCMNext, and you'll get a result in about 6 to 8 weeks. Again, the patient is only billed for HCMFirst or HCMNext and not both. HCMNext is a panel of 32 genes associated with dilated cardiomyopathy, and you get results back in about 6 to 8 weeks. Here's a list showing all 32 genes included in our HCMNext panel. And the two most common genes that I wanted to highlight to people are the Titin gene, which is the largest gene found in our genome. It is 363 exons. And truncating mutations in Titin have been found to be responsible for about 20% of all familial DCM. So this makes it a very important gene when it comes to dilated cardiomyopathy. Another gene, lamin A, is found in a significant percentage of patients. Up to 10% of those with familial DCM are found to have a mutation in the lamin A gene. The rest of these genes together make up a very smaller piece of the pie. So acquired dilated cardiomyopathy makes up about 50 to 60% of all DCM. This is a form of dilated cardiomyopathy in which patients get it secondary to some other cause, most likely ischemia following a heart attack or a stroke. This type of dilated cardiomyopathy is not inherited. So all forms of acquired dilated cardiomyopathy really need to be ruled out before considering genetic testing. And if the patient does not have an explained cause for their dilated cardiomyopathy, then it's considered idiopathic or familial. And the prevalence of familial dilated cardiomyopathy is thought to be very similar to the prevalence of hypertrophic cardiomyopathy, but this isn't really documented. There's been a couple studies to look at it and found a much lower prevalence, but everyone seems to think that it should be higher than what we've actually seen in studies. HRS also recommends genetic testing for dilated cardiomyopathy as a class 1 recommendation for patients who have dilated cardiomyopathy. They've ruled out any sort of acquired causes, and if that patient has cardiac conduction disease, or if they also have a family history of premature sudden death. So dilated cardiomyopathy testing or diagnosis alone is not necessarily enough to do genetic testing, but if you see it in context of a family history of sudden death, perhaps family history of dilated cardiomyopathy, or if that patient also has cardiac conduction disease, makes it much more likely that they have a mutation, and genetic testing would be appropriate. So we talked a little about Titin and lamin A, but this shows you what the pie kind of looks like for mutation distribution for dilated cardiomyopathy. And you can see about 50% of those who have idiopathic, this is the non-ischemic dilated cardiomyopathy, about 50% of them will still be of unknown cause by all of today's testing methods. Titin and laminin make up the biggest pieces of the pie, but there's a few other significant players here. And then the rest of the genes that are found on our HCMNext panel fall into this piece of the pie here. HCMNext is a comprehensive cardiomyopathy panel that we offer that includes all of the genes for hypertrophic cardiomyopathy and dilated cardiomyopathy, along with some other types of cardiomyopathy. It has 50 genes with a turnaround time of 6 to 8 weeks, or you can opt to include the Titin gene with this panel for a total of 51 genes that is completed in 8 to 10 weeks. So we do give you the option of whether you'd like to include Titin or not, and we'll talk a little more about this. As we said, Titin is very important for dilated cardiomyopathy, and we would encourage anyone who has a patient with dilated cardiomyopathy, or if there's DCM in the family somewhat, to include Titin. We do watch for that on test requisition forms when they come in. If someone orders CMNext but doesn't include the Titin gene, and it looks like there is DCM in the family or DCM in the patient, we call them to make sure that they understand Titin is a good idea when DCM is included or is present. These two options have the exact same cost. There is a difference in turnaround time because interpreting the changes found in Titin can take a little longer. So we plan on that when it comes to turnaround time, but the cost of both panels is exactly the same. So there's a lot of overlap when it comes to genes and cardiomyopathies, and this just gives you an idea of the genes that can be found in various forms of cardiomyopathy. You can see there are some that are found in dilated cardiomyopathy, some in hypertrophic cardiomyopathy, and then overlap a group of genes that are found in both. In addition, left ventricular non-compaction here and arrhythmogenic right ventricular dysplasia, you can see some overlap. All of the genes found on this slide here are included in our CMNext panel. You can see there's a couple here that are not in any of the other panels. That's the Ambry gene and TTR for amyloidosis. These can show up with a cardiomyopathy and or other features, so they are part of the CMNext panel but don't fall into any of the specific panels. These genes here are included in arrhythmias, and these are included in an LV&C-Next panel that we also offer, which is a smaller panel of 4 genes, but these are larger cardiomyopathy panels. So CMNext is a panel of 50 or 51 genes, and again, you must choose whether you want to include the Titin gene or not. And this is all the types of cardiomyopathy that can be associated with the genes found on our CMNext panel. So how about a little more information on Titin? Titin is a very large gene, as we discussed, and this is a recent review that was published in 2014 about Titin, where you can reference this and look at it for some more information on your own if you like. But just wanted to show you, this is a picture of Titin, this large protein right here that is involved in holding together the myosin-6 filaments and actinin and nebulin as part of our cardiac muscle. You can see because it's so large, there's a lot of regions here where the DNA may just be filler DNA, and it's not 100% clear whether or which regions are incredibly important because they may need to give the correct flexibility to the protein. Obviously, parts of the protein that are connecting to other proteins are probably important, but there are probably regions within Titin because of its size that are just filling space between one protein domain and another and may not be as important. Also, because there are long ends on here causing nonsense mutations that shorten it, may not be incident or may not cause a problem. So there is, because of the large size of Titin, there are a lot of changes that can occur without necessarily causing a disease. So there's a lot of uncertainties that surround Titin, and I just want to give you a taste of a few of the reports that have been out there. Heterozygous truncating mutations in Titin have been reported in about 3% of people in the supposedly healthy control population. Now, we never know if those individuals who are part of a study in the control population are completely normal, and due to decreased penetrance in some of these cardio diseases, perhaps they do necessarily carry something, but 3% is a very significant percentage. And so we have to remember that there is a chance of even a truncating mutation in titin causing no phenotype whatsoever. In DCM, however, many more changes have been found, and about 69 have been reported in this particular study in DCM that showed nonsense, frame shift, splicing, and missense mutations to cause DCM. About 30 changes have been reported in patients with HCM. 13% of these only had a change in titin. However, the other 87% had another mutation in an ACM-related gene mutation, or an ACM-related gene. So it's difficult to say whether the titin mutation was really modifying their phenotype or whether they truly had HCM due to another gene and the titin finding is just incidental. It can be really hard to tease these things apart. However, out of all these 30 changes, only 9 out of the 30 were true loss of function mutations. About 40% of our previous variant findings on our cardio panels were found in the titin gene. So Ambry Genetics did do cardiovascular genetic testing done in the past, and we have relaunched using new, what we think, better panels for cardiovascular testing. And part of the reason that we weren't happy with our testing before is because there was such a variant burden, and we wanted to do some things to improve the panel. And part of that is that we decided to use the cardiac-specific isoform for titin in hopes that this is going to decrease the number of variants that we discover. We also decided to offer the option to the clients to decide whether they want to include titin or not, both in the instance of not having to, or both for the benefit of not having to explain those changes to patients when we think that they're very, very unlikely to mean anything, and from a lab standpoint, saving us a little time on the interpretations if those are something that you're not going to take into consideration for the patient anyway. So because of this large variant burden, we thought we needed to think about titin a little differently. But we have to remember that about 20% of all patients with dilated cardiomyopathy have a titin mutation, and this is what was quoted in gene reviews and the pretty accepted percentage. So we include titin in our HCMNext panel. It's a very important gene with DCM, and anyone who is pursuing CMNext or CardioNext and shows any signs on the test requisition form that they have DCM in the patient or their family, we strongly encourage including the titin gene, and we will even call to discuss that with them. But outside of dilated cardiomyopathy, the significance of titin alterations remains unclear. Most of these, even if they're nonsense mutations, will probably be interpreted as either likely pathogenic or as a complete variant of unknown significance that we can't interpret at this time. So in summary, our options for cardiomyopathy testing include the HCMFirst and HCMNext panels for hypertrophic cardiomyopathy, DCMNext, a panel for dilated cardiomyopathy, ARVDnext, which is 8 genes for ARVD, LVNCnext, which I didn't talk about in more detail here, but does have 4 genes for left ventricular noncompaction. And then our comprehensive cardiomyopathy panel is CMNext, which is 50 or 51 genes for inherited cardiomyopathy, depending on whether you choose to include the titin gene or not. Now, CardioNext. CardioNext is our most comprehensive cardio panel that we launched recently in January. It is a panel of either 83 genes reported in 8 to 10 weeks or 84 genes reported in 10 to 12 weeks, again with the option of including titin or not. And again, titin, whether you include titin or not, it does not change the price of the panel at all. It just slightly slows down the turnaround time. And CardioNext includes these 84 genes that are associated with all the types of cardiomyopathy and arrhythmia that we talked about today. In addition, there's a few genes on it that are associated with muscular dystrophies like Ambry muscular dystrophy and the dystrophin gene for Duchenne muscular dystrophy, because these are These are diseases that can cause cardiomyopathy, and some patients can exhibit just cardiomyopathy in these conditions. In addition, there's some genes associated with congenital heart defects as part of our CardioNext panel. So this panel includes all of the genes in all of our cardio panels that I've discussed thus far, and a few other unique genes that are included only in the CardioNext panel. This shows you how there is some overlap between the arrhythmia genes and the cardiomyopathy genes. You can see a lot of genes associated only with cardiomyopathy, a lot of them only with arrhythmias, but there is a chunk of about 10 genes here that overlap between the two. And then these genes up here are mostly the genes associated with congenital heart defects, but I'll go into each of these in a little more on the next slide just to show you why we've included these genes as well. But this panel can be an excellent option for those families in which you see maybe one patient who has dilated cardiomyopathy, and then you take a family history and there is some significant arrhythmia in the family, but it's not a really clear diagnosis, and there may even be some other types of cardiomyopathy in the family, or you may even see an unusual heart defect. That would be very appropriate for the CardioNext panel. In addition, when you see those unusually young onsets of cardiomyopathy or one of these other diagnoses, this may be an unusual gene in one of these that you would find on our CardioNext panel. So those genes that are unique to the CardioNext panel, as I said, include mostly genes associated with congenital heart defects. These genes listed here, which TBX5 is in the Holt-Oram syndrome, and TBX1 is the gene that is in the region of the 22q11 deletion and causes a very similar phenotype to 22q. And then these other genes that are associated mostly with just isolated congenital heart defects that run in families. The JAG1 gene associated with Alagille syndrome is found here because some patients can show up with just heart defects or heart issues, similar to the Barth syndrome gene. Then we've included a couple other genes associated with familial atrial fibrillation and a type of long QT syndrome. These genes were felt to not be at a high enough risk or to be found to have enough data to really include them in any particular panel, but we did put them in the CardioNext panel if people are interested in doing the largest cardio panel we have and getting information about those genes. Now I'd like to talk a little about our testing for aortic aneurysms and dissections. Mostly this is our TAD-Next panel, which we actually launched back in November, so prior to the launching of our cardiomyopathy and arrhythmia testing. This is a panel of 20 genes. It gets reported in about 6 to 10 weeks, and these genes are all associated with thoracic aortic aneurysms and dissections. As you all may know, there are several conditions like Marfan syndrome and related conditions that have aortic aneurysms and dissections as a feature of those conditions. And then some patients may just have thoracic aortic aneurysms and dissections running in a family, or what we call familial TAD. So I'm not going to go into each of those syndromes that falls on the TAD-Next panel in more detail because I'm sure if most of you are genetic counselors, you're familiar with those conditions and can find that information. But I thought I would talk a little more about the non-syndromic TAD because that's most of the genes that we added to our panel to make this TAD-Next panel. Thoracic aortic aneurysms can run in families in an autosomal dominant pattern. And this is when aortic dissection, aneurysms, or aortic dilation, aneurysms, and dissections can occur without the other skeletal or connective tissue features of some of these other conditions. And about 20% of people who have a thoracic aortic aneurysm will have a first-degree relative who also has thoracic aortic disease. So it can be highly heritable in instances, but unfortunately we don't understand a vast majority of these cases. So if we look at all the non-syndromic or familial TAD, about 75% of it is not explained at this point. However, there are mutations in about 6 genes that have been identified in TAD, and ACTA2 accounts for about 15% of those overall, making it the most significant piece of the pie. And then other will include the other 14 genes that are included in TAD-Next. And you can see some of these genes that make up a couple percent each, with TGFBR2 being the most common at about, I think, 3 or 4%. So similar to the other cardio conditions, there's a lot of clinical overlap when it comes to thoracic aortic aneurysms and these genes. These genes are all associated with, they can be associated with vascular problems. They can also be associated with connective tissue problems like the Ehlers-Danlos syndrome. They can have features very similar to Marfan syndrome, like the dislocation of the eye or the hyperextensible joints, or just the Marfanoid habitus. Some of these genes are associated with arterial tortuosity. Some can be associated with aortic valve problems, like a bicuspid aortic valve. And these genes are mostly just associated with the aortic aneurysms and none of these other features. A few genes on the panel are associated with intellectual disability, and sometimes you can decipher those out, but there is a lot of overlap and variability here, which makes a large panel of 20 genes a very good option. So as far as our testing options for TAD, the large 20-gene panel is not your only option. You can also order, if you see a patient who you think is very, very likely to have Marfan syndrome, and as genetic counselors, we are very familiar with this condition, or we work with geneticists who do a really good evaluation for Marfan syndrome, it may not make sense to do a whole 20-gene panel right away. You can order the single gene of SBN1. You can also order it as a reflex to TAD-Next. So if it comes up negative, it will reflex to TAD-Next. Similarly, the Ehlers-Danlos vascular type is a condition that some people feel comfortable diagnosing themselves and want to do testing for that gene right away. And if they do, then they go ahead and order the COL3A1 gene. And again, you can order it by itself, or you can reflex to TAD-Next if it's negative. So hereditary cardiovascular testing is very important because in some of these conditions, sudden death can be the very first symptom that happens, whether it's because of an aortic aneurysm or it's because of a sudden cardiac arrest due to a cardiomyopathy or an arrhythmia. It can happen without any other symptoms that brings the patient to the cardiologist. So one of the most important reasons to do this testing is so that we can do genetic testing earlier in life and then get screening for that patient so that we can prevent that sudden death from occurring. Ambry Genetics was the first lab to offer clinical next-generation sequencing in 2007, making us a great partner to help you with this testing. When we started next-generation sequencing, shortly after, it was started in many other labs across the country. So we were really a leader in this field. And now we offer about 25 different panels across our laboratory using next-generation sequencing. This gives us the expertise and the right experience that you need. As soon as a sample arrives in our lab, it is reviewed by a genetic counselor to make sure that the testing was ordered was appropriate. We check the quality of the DNA to make sure we have enough DNA and that it's good enough quality. And we check the patient's insurance to see if the patient's, what the out-of-pocket cost for the patient is going to be. If the expected out-of-pocket cost is anything over $100, we do contact the patient directly, discuss this with them, what the expected cost is going to be, discuss possible payment plans, and make sure that they do want to proceed with testing. So you can be assured when you send it to us that we're not going to just continue the testing and your patient's going to end up with a big bill or anything. Now, many of you may be familiar with the steps involved in next-generation sequencing, and I'm not going to go into great detail on this, but wanted to highlight a few important steps along the way. Next-generation sequencing, we require at least 50x coverage, and this reduces the risk of allele dropout and any any errors happening here. We also use Sanger verification to verify any findings and variants of unknown significance that are found. We verify using Sanger sequencing, and this greatly helps us avoid false positives. Our bioinformatics pipeline then filters the findings for our reporting team that increases the confidence that these are findings you really want to know about. And then our reporting team, which is made up of genetic counselors and lab directors, works on getting you a clear results interpretation that you can understand and that provides all the information you want. Here's an example of our cardio report so you can see what all goes into it. You can see the demographics. The results is clearly written out with a summary in all caps and bold telling you if a mutation was found or not. We give you an interpretation, which is clear bullet points about what might be recommended next for the patient, along with some mutation information and gene information. If there's a variant of unknown significance identified here, we will also attach a couple pages of all of our reasons that we have interpreted something a certain way. So if it was even if it was a variant likely pathogenic, you will get two nice color pages that show you the evolution and the protein structure and other things that we took into consideration when writing our report. And I know a lot of genetic counselors really appreciate the extra information that they get so that, we know that interpreting this change is something that you, the client, and us, the lab, really do together. And by giving this information to you, we enable you to take part in that process as well, because you really know the patient and the family the best. In addition to your report, on the last page you will receive what we call an Understanding Your Results page. And this is a page that's not specific to the gene or the specific mutation, but it will be a page specific, for this example, for a positive hypertrophic cardiomyopathy test. This is information for patients. It's written towards patients. This was written by genetic counselors in our lab and reviewed by many genetic counselors. So that we feel this is information that would be helpful for a patient and easy for them to understand, so that you can hand this to a patient and they can take it home and refer back to it when they have questions. It tells them what things they should discuss with you, the genetic counselor, or their clinician. And it tells them what next steps they may want to take, and it includes some resources like the National Society of Genetic Counselors or the Hypertrophic Cardiomyopathy Association. It also shows them nice diagrams to show them how this runs in the family. On our negative reports, it gives them a pedigree that shows them which of their family members should still be following with a cardiologist for screening recommendations, because we haven't identified a mutation. That screening of family members is still very important. So Ambry provides a lot of supportive clinical education. We have 15 field-based genetic specialists, most of which are genetic counselors or other people well-trained in genetics across the country, and they can help you with Genetics 101 training or detailed understanding of specific genes, tests, and patient care. They are great at going over some of these test results if you are fairly new to cardiogenetics, or if this is a result that you're not comfortable with. They will be happy to go over these with you and help you figure out the next steps for your patient. In addition, we have clinician brochures available on our website to explain all of these tests. We have other clinical tools available. I'm currently working on some counseling aids that we hope to have available soon. We provide webinars, as you're aware, and as you're sitting in on now. I want to also call your attention to anyone who may not have seen the webinar last month. Amy Stern did a great overview of cardiovascular genetics. It's a very educational webinar on all of these conditions, and why I didn't go into much of the clinical information. But that webinar is still available on our website, recorded for any of you to listen to. In addition, we're working on patient guides. We have these available for some of our other tests, and they will be available for cardio tests soon. And these will be guides that you can provide to your patients. So Ambry Genetics, I hope you've seen through all the testing that we've reviewed that we'd like to provide a lot of flexible testing options. We know that all of your patients are different. And if we give you one testing option, that may work for a couple patients, but it's not going to work for a vast number of your patients. And it's not going to be the best care you can provide. So by providing you with single gene testing, tiered tests, large panels, as well as whole exome sequencing options, you can really decide what's the best for each of your patients and get the best results possible. We have other things that can make our testing extremely convenient. So we accept both blood and saliva samples for all of the testing we discussed. We have an online ordering system I hope you're familiar with, Ambry Port 2.0, which is great for submitting orders. and gives you updates on how your testing is doing and what status it is, and even with insurance authorization status for every sample. So all of that appears online, and you can check here and see all your patients in one place and where their testing is at, so that you can better determine when you might expect a result. In addition, we have a paper-based option available, which also makes it convenient. And even if you choose to do the paper-based option to send in testing, someone at Ambry enters all of that information into our online portal so that you will still be able to see the test status updates and insurance status for those patients in the online portal, even though you chose to use the paper option. So the sample is sent by FedEx by our kits overnight to Ambry, and most of our panels are reported out in about 3 to 8 weeks, depending on which panel you selected, and you get results sent back to you. If we receive a sample and the test is not ideal, we will call and talk about it and just make sure that that's what you meant to order and that an error didn't occur. If the patient is expected to pay more than $100 out of pocket, we will call and make sure that the patient still wants to do testing and see if there's any arrangements we can help them make. We are contracted with lots of major insurance companies across the United States, and we treat all insurance companies like they're in network. So Ambry really works hard at being a great partner when it comes to the insurance company. If you need someone, a real person is always here to answer, and so we really try to be there to answer your questions whenever possible. We know it can be difficult when you're in the middle of clinic and seeing a patient and you have questions, so please give us a call and we will find someone to help you as soon as possible. So overall, this was an overview of our cardiovascular genetic testing. We have a lot of panels for inherited arrhythmia, cardiomyopathy, in addition to our previous aortic aneurysm and dissection options. Ambry also offers testing for familial hypercholesterolemia, which I didn't have time to go into today, but information is on our website. So thank you all for your attention, and please contact me directly if you have any other questions or there's anything else we can help you with. Thank you.